And we're live in 5, 4, 3,
2,
1.
Well, good evening, everybody. My name is Jens Chapman. I'm speaking to you from the beautiful SSF studios and conference center here in Seattle, Washington. And today's May 17, and welcome to the second edition of our Evening with a Spine Surgeon. A great idea by my dear friend, Dr. Jack Ziegler from the Texas Back Institute, and we're also accompanied by Dr. Rick Geyer. And our friends had this idea to bring true pioneers in spine surgery in an informal event together here on a screen for a relaxed evening conversation about how and what brought them to where they are. And it's customary to reveal a conflict of interest before we get started. And my conflict of interest is I'm an absolute lifelong fan and beneficiary of Dr. Steve Garfin's knowledge and great professional courtesy. As a very young assistant professor while at the UW, I was looking for a keynote speaker for a conference we put on in Canada. I was nothing but an assistant professor. I reached out to him. He gave me the most gracious answer, and he was very glad to come up to Canada, and I've never forgotten the graciousness of, the preciousness of his time to come up to Canada to be our speaker, and he was, of course, phenomenal, so I've never forgotten this great favor. And here we're indulging on his time again, and I'll pass off to Dr. Ziegler, who will introduce our keynote speaker tonight and our guest for the special evening with a pioneering spine surgeon, Dr. Stephen Garfin. Jack.
Thank you, Dr. Chapman. You wanted to say something about your course this weekend before you passed the baton, didn't you?
Well, I couldn't pass that up. So I have a script here, but I was so taken by the occasion that I forgot about this. Yes, we have a 13th annual multimodal treatment of spine tumors course with a true all-stars lineup. And it's the good Dr. Mendel, who's the course chair of that from Yale. And it's going to be all day Saturday, May 20th. And it features radiation oncology, neuroradiology, and spine surgery faculty from around the globe, including several European speakers. So please join us, as always, for free. The QR code will be available at the end of tonight's conference. Thank you for the reminder, Jack, and thank you for letting me bring in this little plug, Steve.
Thank you, Jens. So anyway, Dr. Chapman gave away our special guest tonight, but you all knew it was going to be Dr. Garfin. And Dr. Garfin is just one of the good guys in medicine, let alone in spine surgery. I've been lucky enough to be his friend for many decades since I started my practice in Southern California. And he and I were able to intersect our lives a few times a year. But at the present time, he is the interim vice chancellor at health sciences at UCSD, unless this has changed in the last few minutes, Steve. He was the interim dean at the School of Medicine. He's been a distinguished professor of orthopedic surgery at UCSD for a long time, and he served his time in the chairmanship for almost 20 years as chairman of orthopedic surgery. Steve was born in Minneapolis, Minnesota. He got his bachelor's degree with honors from the University of Minnesota, his MD degree from the University of Minnesota, and he was AOA. You can see he did his surgical internship and residency at UCSD. He spent some time serving the military obligation in the U.S. Public Health Service. And then he did a fellowship after his orthopedic residency with Dr. Richard Rothman and Dr. Fred Simeone, two of the scions, two of the roots of spine surgery here in the United States, if not the world. So Steve has a very good pedigree. He's put it to very good use. This is just a very essential distillation of his CV. He's written 152 textbook chapters, 333 publications in peer-reviewed journals. He's made over 700 presentations all around the world, and he's trained 55 fellows and hundreds of orthopedic residents. So he's just been a remarkable addition to the field of spine, and that's one of the reasons we asked him to be our guest tonight. because I think it's important that all of us become a little more familiar with the career paths of some of the giants in our field before they retire and move on. So I'm glad we were able to grab Steve, even though he's moving up the administrative ladder. He's still a clinician. He's still one of us. So, Steve, thank you so much. And I thought I'd share this with you, Steve. This is I put this together for a talk, and because our careers kind of started around the same time, I thought you'd remember what that instrumentation is. That was one of the first things we put in at Rancho, actually. But for the younger people who are watching, these were not rods, so they were pure distraction rods, and we thought these were the best things since sliced bread. Unfortunately, throwing every level into kyphosis. Steve and I lived through the next iteration, which was a Lukey rectangle with sublaminar wires. Again, thinking we were God's gift to the world because we could do this successfully, but very difficult instrumentation to help a patient. Then pedicle screws started to be in vogue, and we used them just for posterior instrumentation without really thinking about interbody, relying on non-physiologic posterior lateral fusions rather than structural anterior graft. Then we saw the transition to standalone cylindrical cages, which at the beginning we all thought were going to be terrific, kind of ignoring the biomechanics of stress contact. And we saw many of these fall into subsidence. And so we backed those up with our new pedicle screw instrumentation, once again thinking we'd finally reached the pinnacle of the mountain. Then we used different structural implants in the interbody space, standalone femoral ring allografts. Then had to back those up with pedicle screws because some of them were not going on to union. We tried for less invasive techniques than open pedicle screws at the time. Percutaneous or MIS pedicle screws had not yet been developed, so we started translaminar facet screws with anterior fixation. Thought again that we'd finally found something nice and much less invasive, and had more issues. And technology's just advanced, and the latest iteration, at least in our hands at Texas Fac, is disc replacement. But it's been a great evolution that I've seen over my career, and again, kind of parallels Dr. Garfin's as well. So that sort of puts it into radiographic perspective. But I think it's time to talk to our guest tonight, Dr. Garfin. And Steve, thank you again for being with us. So let's start out. I just want to start out and ask you, how does a math major wind up as a famous spine surgeon? So if you can tell us a little bit about your background, your family and education, and some of the branch points in your career that sort of steered you into the chair that you're sitting in now. Tell us a little bit about you growing up in Minnesota.
Okay, thank you. And thank you and Jens for this marvelous introduction. Sent chills through me into my hair. I have some tech. So thank you. And thank you for inviting me here. I grew up in Minneapolis, Minnesota. Snow, mosquitoes, hot, humid. July 4th was usually the only good day of the year. And that was my life. I applied. I went to University of Minnesota High School, which was their teaching, where the teachers trained. I applied to the University of Minnesota, just one school, and I got in. I applied to that's where the story begins. There's nobody in my family that has a medical background. I applied. I went to the job board that everybody had at I don't know if they still have them, and plucked off 2 jobs, and I applied for 2 jobs. One was in the lab of a cardiothoracic surgeon, and one was in the lab of somebody in the pharmacy school. They literally, within 5 minutes, both called me. The cardiothoracic surgeon called me first, and I took the job. I hung up. Literally 5 minutes later, the pharmacist called me. It was just a summer job, 15 hours. If the calls had been switched, I'd probably be at Walgreens right now, handing out drugs. I mean, literally, that's what happened. So I applied to medical school. I was a math major. I had no clue what I wanted to do. And I figured with math, I could do almost anything. You can go into business, you can go into physiology, you can go into public health. The only class I never got an A in, and it was humanities, because you had to read, and I'm a slow reader. So anyhow, the lab I was in, his name is Gene Bernstein. I worked the next 3 years with him and wrote papers, and he sent me to surgical societies to give papers. And I sort of liked being in the front of the class rather than being in the back of the class. And then he moved out to this new school at UC San Diego, and I applied for an internship. I still did not know what I wanted to do. So they created a mixed medicine and surgical internship for me, just for me.
Wow.
So I spent 4 months in medicine and 8 months in surgery. And then I went into the military, and my wife at the time felt I was the happiest on my 2 months of orthopedic rotation. And while I was in the service, I got called from all the residents at UCSD and Wayne Akeson to say, come back here. So I applied for orthopedic residencies, and I applied for medicine residencies. And the medicine residencies insisted I do another internship, and I would never do that again. So that's how it transpired. I went into orthopedics.
By default, yeah.
By default. And I took I still didn't know if I liked academics or not. I loved what Gene Bernstein, my mentor, did. I loved what Wayne Akeson, who was the chairman, did, but it wasn't me. So I asked if I could take a year off to be in the lab between my second and third year, and I did. And that's when Scott Mubarak was doing the compartment, and Alan Hargan's the compartment syndrome stuff. Vern Nickel had just come, introduced us to the halo and the lack of science there. Savio Wu was doing soft tissue mechanics, and I loved it. And I don't know how many papers I wrote, how many presentations, but I loved academics. I knew I loved academics. And when the time came, I asked Wayne Akeson what were the coming fields for academics that I could do and find a job. So he said spine and oncology. I could not be an oncologist. So I applied to Toronto. At the time, this young guy named John Kostwick was the fellowship director, Dick Rothman, and John O'Brien in Wales.
Wow.
I got into all three, and my wife said, we're going to Philadelphia.
Because, Steve, at that time, there were only maybe a dozen or less spine fellowships available. It's not like today where there's 100.
Well, those are the three full-time ones. Wiltsey was a 6-month job, and we didn't have any spine. So 6 months wasn't going to do me very well. I mean, I was starting from scratch. And those three schools, the three I applied to is who Wayne told me to apply to. I had no clue about spine. That was before any of you guys.
So you wound up in Philadelphia and spent a year with Rothman and Simeon?
Right, and they offered me a job, but there I was going to be a little fish in a big pond, and in San Diego, the whole city, I'd be almost by myself.
Were you the first fellowship-trained spine surgeon back in San Diego? I guess you were.
Yeah, Steve Pye was there. Those of you who are in the Cervical Spine Research Society knew Steve Pye, but there wasn't much. I was really the first fellowship trained, yeah.
How was the interaction of neurosurgery and orthopedics back then? Was that an inspiring kind of a co-discipline, co-management model, or was it just more one versus the other?
It was a combination. Dick saw this future that we'd all work together and made it work. But he was more of the academician. But Simeone did a lot of surgery, and probably the best surgeon I'd ever worked with, hand-wise. And the fellows went back and forth. The residents did not go back and forth. Then issues, and then Dick got into joints. He got smarter and smarter. He still did he did spine because it was an academic challenge, but he did joints because it was routinized, and he loved it. He operated in a routine. He put out his hand, everybody knew what was going to go into his hand. The next move just followed, which is what I loved about operating with him. But all we did was discs, a couple of necks, and something that Dick understood that was called spinal stenosis. But not a lot of people understood it.
Dick had that very complicated looking algorithm on selecting the ideal patient for a discectomy. And he was really very selective. He was trying to pick only the pure patients with a lot of exclusions along the way.
Yes. And he stuck to it. I mean, he was
really did. And, Steve, I don't know. I think you came through Penn. I don't know where I was, but Dick was amazing. You said he liked a routine surgery. So as a resident, he would make us write down all the steps to do a total hip. And I remember it was like either 121 or 125. And he expected you to do each one perfectly. And it's funny because I still tell fellows that, they need to think about their surgery, practice it in their mind and things like that. So he was very, very disciplined. But when I was there, he, as you said, he had really slowed down his spine. He would do an occasional neck. And Frank Eisman was my fellow at the time. And I learned more from Frank and, because he did all Simeone's cases. And Dick was, doing the total hips and the knees and all the rest. But, I mean, really an amazing guy. And yeah, Simeone was incredible too.
So Dick asked me to come 2 weeks early. I followed Frank and Harry Herkowitz, which was a tough acts to follow, and they were together sharing everything. I was alone doing everything. But Dick asked me to like I'm been dean. I was voluntold to come 2 weeks early to learn how to do anterior thoracotomies and lumbar anterior with Frank. So they put aside a whole bunch of cases. Not a whole bunch. It was only 2 weeks. How many can you do? And that's what I did. And then Frank left after 2 weeks. And now all of a sudden,
you were it
doing anterior stuff.
He passed the torch.
So it took, there was nobody there to help me. It took me 20 hours to do an anterior case.
So who was showing you and Frank how to do them? Frank
learned from Henry.
Yeah.
He was had two fellows, Chips. I don't know why he took Dick's, but.
I want to move fast forward, but we want to go back to the history also, because if we look at the difference of what you experienced and what is going on nowadays, where we literally try to nurture fellows and residents, trainees, in every single step, but with our hands in the field, with our direct physical presence there, because society demands that. How much of your learning was due to this kind of a relatively relaxed supervision where you had pretty specific guidance, but you had to figure out how to do responsible care for patients safely by yourself largely? How does it affect education nowadays? How's this next generation going to have this maturity of responsibility?
That's a really tough question. I mean, you guys are all in the same boat, at least with fellows, and you have to be in the room. The case won't start unless you're there for the timeout. And you have to be there. You got to do something. And the clock's ticking. I think it's much, much harder to learn. I can't run 2 to 3 rooms like I used to run. I never missed the critical part of the case. Same as you guys, but you can't do that anymore. I'm seeing the fellows are much less confident, much less skilled, and they come in confident but without skills. And I'm sure you're seeing that too. So I think we're not helping like we did.
Is that because of
Steve,
decreased
do you think
hours?
it has anything?
Decreased hours, Steve, or decreased ability to manage their own patients during training, like we were able to do?
Yeah, I think it's because we have to be in the room. They can't be in the room. We can't run 2 rooms. We being the attendings, I'm at UCSD still. You can't leave them alone very much. If we have essentially a county hospital like you do, Jens. I mean, you're not there anymore, but you were. And that usually, that and the VA were the residents and fellows' home. And we'd show up when we could, but that's not the case anymore. We have to be.
And Steve, I think that Jack was alluding to it as well. Do you think the reduced hours that the residents are allowed to work has affected them? I mean, I personally think it has.
Yeah, I do too. But we've had it so long now. I can't blame anything on that just because it's there. But it's also, there's a mental set today. If you fast forward to junior faculty, we used to go to meetings, everybody here. I mean, we still do. And we'd go on whenever we went, Wednesday, and come back Sunday, and then do it every weekend. Now and I'm not saying this is wrong, there's soccer, there's swimming, there's gymnastics, there's PTA. They got to be home. They don't want to go to meetings and get involved like we were. They're the sane ones. We were crazy. But they're sort of brought up that way now. And so, yes, it affects them, but there's no way going back, I don't see.
Yeah, I think you're exactly right, Steve. We see the same thing with our young partners and even the fellows. It's a whole different mindset. And well, I'll ask your opinion. So what do you think will make up for the difference? Because I hear from some of my peers, they say, oh, it's going to be terrible medical care. I don't think that way at all. And I have my own feelings why I think the medical care actually will continue to improve and be better. But what do you think is going to make up the gap for the way we were trained and how we think we were the best trained compared to the way they are now?
Navigation and robotics.
Yeah, I think technology is going to make up the big gap.
The trouble is if that's what you're doing, and many fellowships are going that way, and again, I'm not complaining. If you don't know how to do an open operation, you can't bail out if that screw is wrong or too long or doesn't work or the anatomy isn't what you thought it was. And we still do a lot of, I'm not operating anymore. I stopped a year ago, but we're still doing a lot of open. As much for the fellows as for us, because we know how to do it. But I don't know about the future. If what happens if you're in the middle of a case and the emergency power goes on, or the machine breaks and the tech's not there to fix it? I worry about that.
Guys,
Yeah.
I'm sorry, I don't want to interrupt, but I don't think you can see me. It's Bob Hart, but I've been hearing you, and I've been seeing you for most of the meeting. I'm sorry, I'm experiencing some technical difficulties.
We see you, Bob.
Oh, you got me. Well, I was a little late joining too. I was out buying groceries for my wife, as I think a lot of you know, and that ran a little long. It was a bit of a line, and add to that, we just revamped our internet out here, and it's not working well tonight. Go figure. So, but I've really been enjoying the commentary, and one thing I did want to make sure to weigh in. Steve, your history, I mean, we didn't overlap really ever, I think, but we were in proximity. So I was a young med student at San Diego while you were there as, I think, a young faculty. And much more important than any of that is you were a physician to both my wife and to my father-in-law. And for my wife, I'll say there was another very famous spine surgeon. She had a T1, T2 flexion distraction injury after going head first off a bike. And another very famous spine surgeon recommended that she have a long fusion from cervical spine down to thoracic spine. And you saw her and said, well, we can try a CTO, and if you're compliant, that might work. And I think she was compliant. And the funny thing is, both of you told her she was at that time a surgical resident up in San Francisco. You both told her, you might as well leave surgery now because you're never going to operate. And she's retiring at the end of this year. So she did get through it. And I think your advice, had she had the fusion, I don't think she would have. So I think your advice and your treatment was entirely correct. And I'll say one other thing about my father-in-law, who was, famously your patient. And I actually advised him a little bit on his problem. He had an osteoporotic burst fracture. And, he was going to make up his own mind, right? And so he declined to have the kyphoplasty you recommended, which I think would have been the right approach. And he had a miserable time with his back down the stretch. But he always had enormous respect for you. And we've known you, from both a personal and professional level. And I just, what a career, and congratulations.
Thanks, Bob. I think I put Susan in a halo for 6 weeks first.
That may be. I
look at her forehead. Look above her eyes. I think.
Yeah, I think 20 years in, I would have noticed.
Maybe not.
You put him in high.
Steve, let me take you back to those formative years at the Rothman Institute. It's obviously and remained a powerhouse beyond belief, but looking through your CV and your publications, it was just amazing to me to see the bandwidth of basic sciences to clinical things. The halo just triggered that. You wrote some of the main halo articles that were out there. What was, when you came out of Rothman, what was your first scientific impetus? What was the first problem that you wanted to tackle after being exposed to spine surgery in this more or less complete immersion fashion at Rothman?
Spinal stenosis. It was easy. I mean, Dick was one of the few people in the country who understood it. So Ricky got exposed to it when others weren't even thinking about it. The articles, there'd been an article before or two verbose, but nobody read that stuff except Dick. He read everything. It wasn't so much to read as there is today. So it was fine. So I came back, and we, based on the PhDs in the lab that Wayne Akeson put together, well, one of them a physiologist with Alan Hargens who could measure pressure anywhere, you set up a lab, and Bjorn Ridevig came from Sweden, spent a year there. So we had developed a pig model for spinal stenosis and started looking at that both clinically and in the laboratory.
Yes, Steve, coming out of Henry Bowman's fellowship around the same time, I was also, well educated in spinal stenosis. And when I went into practice in Orange County, nobody else was making that diagnosis. Those patients were around, and they'd come in, and, my eyes would open because they had these classic presentation, and they had all been worked up, sent to a vascular surgeon. They didn't have vascular claudication. People told me that they couldn't make a diagnosis. They hadn't gotten a CT scan, or, even MRIs were barely available, but they'd gotten, no kind of workup. So it was really nice for someone who had the training and could make that diagnosis to be able to finally offer them something. And those were some of the most grateful patients that I've ever had in my career. Were people who were, hunched over and barely able to go from their club chair to the bathroom without their legs collapsing suddenly get like a new lease on life. So, it brought back memories when you said that. That was like unplowed farmland, ready for the Minnesota boy to go and start a harvest.
It was. I mean, so Harry, Frank, and I taught the instructional course at the academy for 10 or 15 years. There wasn't anybody else to teach it because I had the basic science. Harry had the clinical experience, and Frank sort of gave the clinical appearance. And there wasn't anybody else, and those rooms are always filled.
It should be one of the simplest surgeries to do, and it's one of the most amazing and can be gratifying if done correctly done surgeries. What I'm worried about nowadays is seeing a lot of tubular surgery done, and again, my practice is full of patients who've had something burred out somewhere, I'm not sure where, and it's kind of very erratic. Going back to this revisionism, should we teach our junior trainees how to do a proper decompression surgery to kind of combat this emerging silver tsunami more effectively, or should we kind of go high-tech into tubular surgeries or stuff like that?
I still think that, maybe we don't make as big incisions. Dick used to say that the wound ends, the wound heals side to side and end to end. Make it as big as you want. Make it easy on yourself. Don't fight it. So, nobody's doing that anymore. But I still think and I hate to sound like an old codger, but just a good open decompression where you see what you're doing. If there's a facet cyst, you get it out. If there's a fragment of a disc, you can see it. You're not hunting and pecking, and you're thinking about it as opposed to just putting in a tube in, doing a small job that may be successful if that's where the problem is, and going home. I think like you, Jens, but we may be dragons.
Yeah. Going to a question in the chat room, we've had a lot of questions and again, a lot of very cool comments about you. Dr. Orson May wants to know, when you moved to San Diego, did that presence of yours in this Navy city, did the interactions with an active duty community shape you either directly through colleagues there or indirectly in patient care? Did that Navy exposure somehow influence your research and clinical activities?
No, it really didn't. They didn't do much spine there. Their population was discectomies. That's really all they did. When I was a resident, I went to the Navy, and the only 2 discs I ever did in 5 years of training was at the Navy. So it didn't affect us very much. Their residents come over to us. We go to them. They eventually got spine surgeons, most of them trained by Alex Vaquero. But all they did was 1 or 2 level discectomies or 1 or 2 level necks. So it didn't affect us at all. It was a different population. I think the question suggests that I take advantage of that with young, healthy people and do something different. No, the answer is no.
Steve, you mentioned spinal stenosis being, a good entree back into your practice. What other surgeries, looking back now on your career, were the most enjoyable to you? What things did you like doing and look forward to rather than kind of be nervous about?
I would be amiss if I did not say pedicle screws, because that too is a story. Everything is a story, as you know.
Yeah.
You think those are going to catch on, Steve?
Well, Harry and I was at Academy meeting because all we had was Academy, American Academy of Orthopedic Surgery. And Harry and I were walking through the exhibit hall, and he ran over and he took me to the very back corner of the exhibit hall. You know how big those are. He said, "There's a guy here you got to meet. You just got to meet. His name is Alan Olson." So in the back of he's the guy who started Danik, and he had this screw, and I remember the year I think 76 or 77. I said I remember the year. Raymond Roy Camille gave a talk at the Academy. You guys probably weren't there, but he was showing screws. He put them in the neck. He put them in the front of the neck, the back of the neck, the back of the spine, and I never forgot that. And said, this is worth doing because we're missing something with these hooks and rods that we're putting in everybody. So I have this structural fondness for screws because I was just one of the first to do it. Then it still seemed awfully stiff and rigid. And I tracked down, because of Alan Levine, who was my friend, Chuck Edwards, who had a modular system, big, bulky, but modular, and you could pull bones back. You could pull one vertebra back on another and make it look like it's lined up. So that's probably the most fun. On the other extreme is kyphoplasty, which is a home run almost every time you do it. And I was the first in the country to do that with Mark Riley, who came down to help me do one. So the two extremes of surgery are great to me.
Going to the halos one more time, anachronism. Is there any role for halos anymore, or halo traction? Is that something that's an anachronism now, looking back at the groundbreaking work that came out of San Diego and then went across the world for a while? In an adult, is there a role for halo these days?
If we put one on in a couple of years, that's a lot. Usually it's post-op, because you can almost fix anything anywhere today. The reason I got involved in that is I was very fortunate. Vern Nichols semi-retired here and told me how the halo was invented. It was invented for facial trauma in the war by a guy named Bloom. And the reason we did 6 inch-pounds of torque tightening is that was the strength in Jacqueline Perry's hand. And they chose her because she wasn't big and tough like Vern Nickel or Mooney. And they thought it'd be safer if she put them in. That was the science behind the halo. So that was virginal territory to study. But then my next goal was to get rid of the halo, which is why I got involved in cervical plating. So I don't think there's much role. There's always going to be some role, I think. There's just some things that are too hard to fix, but that's pretty limited today. What do you think?
It's been one of those things that I've still used it as a compliance tool for patients where I have serious issues with compliance, but it's become very rare also. And I always remember your disciple, Alex Vaccaro, debating me in a variety of meetings with the hands on the bars of, let me out of this prison. And I always laughed at him because we had a pretty good success rate following your principles at Harborview, but it is not very well desired by patients nowadays. It's not hard to talk them out of it.
Right, not desired by patients or physicians.
Yeah, it's a lot of work to actually maintain them and keep them intact over time.
Growing up through county facilities with county patient populations, it was always fascinating. The patients you'd put in halos and they'd never come back for follow-up. Right. And you get a report every once in a while that one was sighted, crossing a street somewhere months later with the halo still on.
One of my favorite groundbreaking papers of many, it's literally just amazing to look through all the things that you've pioneered for us and for the benefit of our patients, was something that we face every day here just about in Seattle and probably in other cities also. We have a lot of discitis, osteomyelitis patients. And I think you were the first one to actually publish on an off-label use of BMP in these patients. And I do think that we somehow have to credit you way more for that, because this has been one of those breakthrough applications. I want to emphasize I'm not in any way conflicted by the company or output thereof, but this has been a amazing feature, and it's, I think, not well enough taught. How can we get these breakthrough ideas into a better mainstream packaging without falling victim to regulatory concerns?
That's really a good question. I think there's more concerns today, more legal concerns, probably not medical, but legal. But I had fought through the pedicle, stuff. So I was well attuned to the rules and the laws of what we can do and can't do. And so it made sense to me, when you have infections, what you want to do is get blood to the bone so it can get the antibiotics to the bone. And BMP was easier than putting in all these rib grafts we were doing vascularized rib grafts. It just seemed to make more sense to me. And the hospital supported me, and I didn't get any special permits or permission. So you can do off-label stuff if you feel it's indicated and justified. I didn't know if it was or not, but we tried it, and it works. The next step, it's harder and harder I think, to do the stuff I did. I mean, to just have somebody come down from San Francisco into my OR and do a kyphoplasty. The first one. You can't explain it. You can't do that today.
Yeah. Steve, I want to congratulate you on your timing in terms of when you walked away from doing surgery. And, it is an era where a lot of us are very frustrated with the work environment. And, I think everybody still loves teaching. Everybody still loves, thinking and trying to move things forward. Everybody still loves working in the operating room with the nurses and taking care of patients. But the environment has become extremely difficult. Having said that, I wanted to make sure to congratulate you on the work you did around getting adoption and approval for use of pedicle screws. And that was kind of a singular moment in spine surgery, and you were certainly at the forefront of that. And, so congratulations on that work. Absolutely. And last, I wanted to ask just a final question, going back to some of the stuff with education. And I agree with a lot of the sentiments that were expressed earlier that I think we need to rethink how we are training spine surgeons, and particularly within orthopedics. I think some of the 80-hour work week issues have been aggravated by, COVID. But even without that, I think we need structural change in the way we train our residents so that they see more of whatever specialty, but certainly spine. It's really the only one I know, but I think they would benefit in the same way from earlier total joint exposure, if that's what they want to do, or sports exposure. Get them into some track that by the third or fourth year, they're doing what they're going to ultimately end up doing. And I don't know of any programs that are really signing up for that. I think it's compliant with current board requirements and ACGME requirements. I wonder what your thoughts are. Does that resonate?
It does. And so I said early on I didn't know what I wanted to do. But I think I'm, in today's world, very rare. Most people have a clue. I really had no clue, but most people have a clue. And so in all specialties today, not just orthopedics. So you wonder if we need exposure to everything. Do we need to spend time on foot and ankle if we're going to be a hip and knee surgeon? Well, maybe you do, because now there's ankle arthroplasty in our, maybe you do. But maybe the residency could be less and the fellowship a year longer. If then,
Steve, Bert Mooney talked about that when he was in Dallas. His vision was to have a 2 or 3 year residency and then a 2 or 3 year fellowship in what you're doing. But I think back then it's probably still the same problem, is to try to get it through the academy. But I think that makes sense, and maybe someday we'll migrate to that. But it seems that when we see our applicants, they have so many publications for fellowship, that is, and they started, in the very beginning of the residency, and some have unbelievable CVs, and they already knew that they wanted to go into spine, but yet we still have them rotate around in every little area. It's almost like when we require general surgery for, previous specialties in the past. But I mean, what's your feeling? You think anything like that will ever happen, or is it going to be a long time?
I think it's a long time. I mean, medicine essentially does that today, right? They have 3 years of general medicine and then 3 years of fellowship, and most of them take fellowships, though there's a lot that go into general internal medicine. So that's a little different. There's very few that go into general ortho today.
Right.
99% of our residents do a fellowship. And when they get out, what they want to do, they don't want to spend time doing general orthopedics. They may have to, but they hate it. So I think that Bob was getting at indirectly by saying their senior year, they're doing what they wanted, their specialty. Right, Bob? Isn't that what you were hinting?
Yeah, no, that's exactly what I'm thinking. And, the history, ortho has never done this, right? But general surgery has done it repeatedly. And, for cardiovascular, vascular, urology, plastics now. I mean, once we were part of general ortho. But ortho has never really sort of offered or created accelerated pathways within specific ortho specialties. And you're exactly right, Steve. I mean, it is 97, 98, 99% of our graduates, those are statistics. That's data. That's not conjecture, are doing a specialty after residency. And, I did 5 years of ortho trauma, general ortho trauma. And, I think most of our graduating residents would be happy to do that, which is the one area, trauma call is the one area that, we could all pay back as a general program. You wouldn't lose that, I don't think.
Yeah.
Well, we won't solve that tonight, but let me switch into one other device-specific question, and I'm going to see whether I can stir up some controversy, because we have two true pioneers of disc arthroplasty here. So you've been a pioneer in so many areas, Steve. What are your thoughts on motion preservation and disc replacements in the cervical and lumbar spine, if you want to differentiate it?
There's clearly a place for it. There's clearly a place. I don't know what. Jack has done it. Ricky's done it. They've done it on one level, 2 levels, multi-levels. It's still picking the patient. The one with too much narrowing of the disc space, maybe that'll change. Without osteophytes, maybe that'll change. Posterior osteophytes, that you have to chip away part of the end plates. I think in the right people, it's great. It's great. I don't know how else to say it. California was San Diego was very hard to put them in anywhere. Very late to get approval. So even though I was on 2 design teams for artificial discs and 3 clinical trials, we never did very many, because it was not a community that did artificial discs.
I think also it was IRB issues at the university that delayed your ability to get into the studies until towards the end.
Yeah, today, to date, we have that problem, that by the time we get approval, the studies are over.
Right. And that is not unique to San Diego. We see that all over the country. And one of the most frustrating.
That's good to hear. Thank you.
Yeah.
Now, industry is pushing somehow, or organized medicine is also supporting fusions, for instance, in the neck far more than disc replacements. There's a differential pay gradient, and industry is pushing these very high-tech integrated fusion devices for the front of the neck, mainly some biomaterial and some screws that anchor up and down through the device. What do you think about the role of industry in kind of pioneering new technologies, and what is the reimbursement situation in terms of guiding physicians towards one versus other procedures?
It's a question I don't know that I can answer. It's a great question. I grew up, my career related to industry. Screws were industry driven. Kyphoplasty was, and osteoporosis was industry driven. SI joint was industry driven. Almost everything I've done has been industry driven. I wasn't smart enough to get royalties or anything. I just gave them ideas because it seemed right. But we all worked together. It wasn't one industry fighting the other. It was almost the same consultants were working everywhere. Now there's so much industry. And we were fortunate. Everything was new. Now what's new is a red screw versus a green screw. Depends on what color you like. That's about what's new with pedicle screws, I think. If you look at it in the big picture. The discs are new, but there's however many there are. Ricky and Jack know better than I, maybe 10, 15 different discs, and they're cannibalizing each other, the companies. And they're watching their back more than they're watching us, I think. So it's just a whole different environment. Jens, I don't know how to answer the question.
Yeah. And I think Jens is right, because you have the industries that are really based upon all the various fusion techniques, the new expandable cages that can be put in all different ways, and the ones that'll give lordosis a better footprint. But there's really not been a lot of research into disc replacement, although we had 12 that are now approved, 3 are off the market, so we have a choice of 9. So in the lumbar spine, we only have 2, which is kind of crazy, and Jack will attest to it, that some of our happiest patients are the properly selected disc replacement patients that are so grateful. And we've been doing it now for 23 years. And it's funny when we have to do peer-to-peer with the insurance and they say, oh, well, this is experimental. Like, really? 23 years? You think there's not enough data after 23 years? But
so let me quibble with you for a minute, Ricky, because of the message you sent all those years, over 20 years, was it's a better operation in the right patient.
Right.
Technically, maybe a little harder because you have to get it in perfect, unlike a fusion where you can put it in lopsided.
Right. Very forgiving.
But once you've gotten it in, you're pretty much done. Right.
Right.
You don't put them in a collar. You don't get x-rays every X amount of time. You're not following them for a year. You're not having to go back and take the plate out because they can't swallow. So what I think you should have done, instead of, because Jens wanted controversy, so here's the controversy. Instead of trying to say we are equivalent financially to a fusion, because you don't have much follow-up, you don't have a collar, you don't need a lot of PT, you should be charging less for the artificial disc. You have less complications, you have less everything. And unfortunately, when Jens asked the question about money, I think it would be easier to get through insurance if you don't need the big global follow-up for a year.
Well, the fact of the matter is, Steve, for the cervical disc, we get reimbursed about 60% of a fusion. For the lumbar disc, if you do, it depends on how you do the fusion, but you can get reimbursed about 9 or 10% of what you would get for a 360 fusion. So, you would think that the insurance companies say, hey, this is great. and we looked at our long-term follow-up. We're going to publish this. Our revision rate of the lumbar disc with up to a 23-year follow-up, not all, obviously. It's a 2 to 23-year with an average of about 90 months, is only 1% revision at that level. Now, it doesn't mean to say they might not have more surgery at another level, but so do fusions.
Okay, well, then I stand corrected. I'm sorry.
That's right.
I do think the lumbar is a touchier one, because Jens asked neck versus lumbar. I mean, neck is an easier decision.
Yeah, the next degree
is harder if you don't have the kind of vascular surgeons you used to have, because you corrected me a couple of years ago that you don't have that person anymore that gets you there in 20 minutes necessarily.
Well, they're just slowing down. They're slowing down, but we still have it.
I got it.
But now we have a lot more.
Steve, can I ask you a gray hair question? It's as a surgeon who's given up doing the surgery, and it's just something we touched on with the ends before, and I think Bob Hart kind of tangentially mentioned it too. Any thoughts on when surgeons should stop operating? Is there a technical test or some intellectual testing, or just a hard stop at a certain age or a number of cases? What do you think is appropriate for surgeons who are aging out as to when they should call it a day, or can they make that decision themselves, or do they need an external monitor or friend to tell them that?
How long do I have to talk, Jens? When are we stopping?
The microphone is yours. The camera is yours. I mean, we had you scheduled for another 5 minutes, but it's such a treasure to have you here until the lights go out, until you run out of steam. Go for it.
Okay, so the one question...
I'm sticking around. I'll say that.
The easy part of your question, Jack, is does the surgeon know when to not operate? No. They may know when, but they don't honor it. So I think that's not that's the hard part. When I started doing the big complex stuff, which is really all I've ever done, I would talk, if whatever partners I had, my nurse practitioner, my department business officer, tell me when I should stop. Tell me when I'm causing complications. Tell me when my time's up. And I would ask, I mean, not when I was 45 or 50, but as time moved on, I asked, and a couple things happened sort of concurrently. I became dean, so I didn't have all the time to make rounds, and I couldn't do complex stuff. I couldn't be in the OR 8 hours a day. Even if that was 2 cases, I just couldn't do it because I had to be able to get to the phone if I needed it. And then they made me vice chancellor, which took away all available time. So that occurred a couple of years ago. I started to wake up in the morning before a case, and I would say to myself, should I have stopped yesterday? I didn't stop yesterday. I mean, this has been going on for a couple of years, but I realized if I'm saying that, I may not be the surgeon for this patient to do the big stuff if I'm questioning me, when you can't do that in spine. I mean, you can if you're doing, somebody's making the approach and you're just doing a 5-1 fusion, you can probably do it till you're 92. But if you're doing something, you're digging out the dura, treating infections, and that's what I was always worried about, not so much going to court, but not being the best I could do. And then my former department business officer who now runs the OR, came to me and said, you wanted me to tell you when it was time. I think you ought to think about it in the next year or so. You're getting a little slower. Nothing bad was happening, nothing bad at all, but it just, so I said, okay, maybe it is time, using the vice chancellor stuff as an excuse, but I was 75, and I could hear some lawyers saying, you should have stopped yesterday, right? You're 75. I don't have a tremor. I don't have anything. But then as dean, I'm now seeing, hey, our medical staff executive committee, everybody has them in the hospital. They're just from every department. I have brought three surgeons, forward that they should have. The question is, should they have stopped? Should they still be operating? I don't think it's a physiological decision, not a 65-year-old decision. Kaiser makes you stop at 65. So we have a non-mandatory senior, I don't even know what to call it, senior advisory review. If you want, you can be mentally, psychometrically, physically tested. But if you're local, you got to go to Colorado. Not many places have them. And then you got to see a neurologist. Then you got to see a psychiatrist. It's a burden. At the stage that they get reported to the MSCC, it's much better. The medical staff executive committee, it's much better to stop it yourself earlier, even if it's a year earlier. And everybody has a tremor, and everybody gets a tremor, some just mild physiologic. Some places, I'm told, mandate that testing at a certain age, and I think that age is 70 or 72. That, to me, is more appropriate than 65. But that's just making up a number. But that's coming because of the people I work with these three surgeons. They feel this is coming, that it's going to be mandatory testing at a certain age, that the medical staffs, private or academic, will mandate it.
So this is kind of a very, very important topic and near and dear to my heart as I'm 63 now. And it's not a number, but there is a number concern for society that we have to respect. Let me explore as the final thing one of the major accomplishments of yours, and that is stepping outside and beyond the realm of orthopedic surgery, beyond the realm of spine surgery, and actually becoming a senior administrator in one of our major medical schools. This is something that happens very rarely because usually people in internal medicine or so who have the time during daytimes to attend these political affairs advance. Is this a pathway that you think we should do or try to pursue more aggressively? And how did that work out for you in terms of your personal satisfaction of a rich career of academic and surgical accomplishments?
Well, thank you for those comments and adjectives you just threw at me. When I was your age, literally, I started to ask around to the CEO of the hospital, to the chancellor, to the vice chancellor, what am I going to do when I stop operating? I wasn't thinking of stopping operating, but I had no clue what I was going to do because I'm not a gardener. I don't ski. I don't golf. I love what I'm doing. The advantage of academics is you can teach, you can do clinical, you can do research, you can do administrative. And I was pretty successful, I'm told, as a chair. We never ran out of money, and we had a great department. So I had these higher level people above me trying, as friends, asking me asking them, what can I do, and them thinking about it. How the deanship came up, I can't tell you. That was just sort of voluntold one day I would be the dean, much to the dismay of all the researchers on campus. So once they saw my CV, they understood because I have had VA grants, I have had NIH grants, I have had Department of Defense grants. And it's helped. It's helped be a dean. My home is orthopedic spine surgery. My comfort level is orthopedic spine surgery. But there's got to be something else. And for me, it's work. So this is broad. It keeps me maybe mentally young. But this is not what I dreamt. I thought I'd be like a quality assurance officer or
a pharmacist, yeah.
or a pharmacist, go back to school again. Yeah, it was actually full circle here, and the time's up.
Steve, we're glad that your home is our home, and you are a treasure, and just, wonderful human being, and just a tremendous career. So, thank you very much for carving out some time with us tonight, and thank you to all the other moderators and all the attendees. It's been a wonderful experience. Thank you.
Well, thank you. I'm honored. I hope I didn't waste too much time for everybody else.
It was awesome. And
no, it was great, Steve. Thank you.
And Larry Marshall wants you to know he enjoyed every single minute of it and beyond. So he was watching with bated breath, and everybody thinks the world of you. So thanks for all the work that you've done and that you continue to do, and the inspiration based on reflections that you provided us tonight.
So Fred Simeone sent a letter to Larry Marshall when I went back there, and John Oxley, the two neurosurgeons, said, "You take care of him." So Larry and I worked very closely together for many, 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 many years. So hi, Larry. I didn't know you were on, if you're still on.
Wonderful and well-deserved. Steve, thank you.
Thank you.
Yeah. All right. Take care,
Good
everybody.
night, everybody.
Thank you so much.
Keep up this great program you guys are running.
Thank you so much for your time and quality thoughts.